Hi, welcome to the NEET PG Core Revision Series, where I, Dr. Deepika Tikku, will take you through the most important topics in pharmacology which are asked in the NEET PG examinations. So, moving on to the topic of pharmacodynamics. So, let's see what are the most important things that you must know from this topic. So, first we are going to talk about enzyme inhibition. Now, in the enzyme inhibition, you're often asked in the exams by they give you a graph. It can be an image based question, and then you're asked to identify what type of enzyme inhibition is this, right? So, there can be two types of graphs. One which are parallel to each other, okay, and in the other it can be a downward shift, right? So in both the cases what you have to do is you have to identify the type of antagonism. Now this is, we are talking about the enzyme inhibition here. So in enzyme inhibition you will be asked to identify the type, or maybe sometimes what is the Km and the Vmax. So let's understand this first. In case of a competitive antagonism, if the graph shows this kind of parallel shift, right? So this is a competitive antagonism. Competitive antagonism where there is a parallel shift or shift towards the right. So here we say the maximum velocity Vmax in a competitive antagonism, it remains the same. So Vmax in this case is going to be the same, while the Km, that is the substrate concentration which is required to achieve 50% or half of the Vmax, that is going to increase. So the Km, if you see, because of the rightward shift, the Km is going to increase. So in a competitive inhibition, in case of an enzymes, the Km is going to increase, but the Vmax is going to remain the same, right? Now, in the non-competitive graph, there will be a downward shift, right? So this means that the Vmax has dropped down, right? So the Vmax is going to decrease. But the Km, which means the affinity, that is almost the same. So the Km remains the same. So make sure that we know this thing. In competitive enzyme inhibition, Vmax remains the same and the Km will increase, while in the non-competitive enzyme inhibition, the Vmax will decrease while the Km will remain the same. Now, there is another type of graph on this very concept which is called as the Lineweaver-Burk plots for enzyme inhibition. So here what is simply you need to know is you need to identify the types of inhibition, whether it is a competitive inhibition, whether it is an uncompetitive inhibition, or whether it is a non-competitive inhibition. You just need to identify this here, right? Alright, so let's see an easy trick to identify this. Now, if you see this kind of graph, the first one where you see a cross, they are crossing at points, so it's a cross, okay? Cross starts with C and C stands for competitive, right? So it is a competitive inhibition, right? This cross means that the Vmax, that remains the same because they're crossing at, this is 1 by V. So this crossing means that they are intersecting at the same point. So Vmax remains the same. And if you see this point, it is representing the Km. So when you give an inhibitor, the Km is going to increase, right? Let's talk about the second graph. In the second graph here, you see these two parallel lines. So you can make a U here, right? Just for your, as a trick to remember. So U stands for uncompetitive. So this graph is of an uncompetitive inhibition. So in uncompetitive inhibition, what happens? The Km is reduced and the Vmax is also reduced. You see here, the Km is reduced and the Vmax is also reduced. Then the one which is left in the V form, that is your non-competitive inhibition. So see, if you put N like this, you can make a V here. Remember, so this V is what? This V is your, this graph, right? It's a simple trick to remember. So this is a non-competitive inhibition, and in the non-competitive inhibition, what is happening? The Km here, that is remaining the same. The point is same, so it is unaffected, while the Vmax here, it is getting reduced. Okay. So this is another graph which can be asked in the exam, and you're just simply asked to identify. So this is the trick to identify. Cross means competitive, U means uncompetitive, and the V means V in the N. That means non-competitive, right? Okay. Moving on to the next question, which is again a graph-based question, again very, very high yield. So this is a graph which is shown of a response versus log dose response curve, and there are four graphs, like one curve is number 2, number 3, number 4. You're asked to identify. So let's see. Drug 1 represents an agonist and drug 2 represents an inverse agonist. Drug 3 represents an agonist, drug 4 represents an inverse agonist. Drug 1 represents an agonist and drug 4 represents an inverse agonist, or drug 2 represents a partial agonist and drug 3 represents an inverse agonist. So let's see which of the following is the correct statement. So first, to identify what is wrong and what is right, we first need to have a basic understanding of these curves. What is 1, what is 2, what is 3, what is 4. So you see here curve 1, if you see, this is getting you the almost the maximal response, right? So we say this has a maximal response as compared to the others. Number 2, the response is there, but it is less than the first. Number 3, you don't see any response. And number 4, you see the opposite response, right? So what we do is here, so a graph which has the maximum response, it is a full agonist curve, right? So number 1 is your full agonist. The second curve, which is showing the response, which is less than the full, it's a sub-maximal response, that is a partial agonist. Antagonist does not have any response of its own. It only has affinity without having any intrinsic activity. So this antagonist is represented by third line. And the fourth one states it's an inverse agonist, which means the action of this is opposite to that of the agonist. So 1, 2, 3, 4 represents full agonist, partial agonist, antagonist, inverse agonist. So let's see from the option which is the correct one. So if you see the first one, drug 1 represents an agonist, yes. 2, inverse agonist, no. So this is not the correct answer. B is drug 3 represents an agonist, no. It represents an antagonist, so again it is wrong. C, drug 1 represents an agonist, yes. And drug 4 represents an inverse agonist, absolutely correct. So this seems to be the correct answer, but still let's go on to the fourth option as well. Drug 2 represents a partial agonist, yes, and drug 3 represents an inverse agonist. Here it is wrong because the drug 3 is an antagonist. So therefore, option number 3 is correct here. Now let's just deep dive in a little more here. So agonist, antagonist, partial agonist, inverse agonist, we know I have defined them. Now they can be also defined in terms of, or they can be segregated in terms of affinity and intrinsic activities. How to differentiate them? So all of them are going to have affinity. Affinity means how much they love the receptor. So all of them, they have an affinity for the receptor. That's why they bind to the receptor. So all of them will have affinity. That's positive for all. But they differ in sense of their intrinsic activity, the response that is produced by them. So maximum intrinsic activity is said to be +1. So I said the maximum effect is seen with agonist. So they have intrinsic activity maximum +1. Now antagonist, it does not have any response or intrinsic activity. So its intrinsic activity is 0. Partial agonist, the response is sub-maximal. So it will be between 0 to 1. It won't be 1, but slightly less than 1. So it's 0 to 1. And inverse agonist, it works in the opposite direction. So therefore, it would be from 0 to minus, or -1 to 0, you can say. So if an agonist is increasing the heart rate, the inverse agonist is going to go in the opposite direction and cause decrease in the heart rate. So these are certain examples. If you see, muscarinic receptors, the agonist is pilocarpine, the antagonist would be atropine. Then a partial agonist example is pentazocine at mu receptors. You can also see here that if we talk about the agonist at the mu receptor, that would be for us morphine, right? Morphine is a full agonist. and antagonist would be naloxone, right? Partial agonist is pentazocine. And we don't have very many inverse agonists in clinical practice, so there are very few examples. So one of the examples is beta carboline, which acts as an inverse agonist for benzodiazepine. So benzodiazepine receptor, the agonists are like diazepam and flurazepam, all the benzodiazepines. The antagonist at that receptor is flumazenil. There is an inverse agonist also at that receptor, which is your beta carbolines. All right. So now moving on to the next important term, which is efficacy and potency. Now we discussed the Km and Vmax before. Now they are usually used when we talk about enzyme inhibition. But when we talk about drug receptor interactions, right? Drug receptor interactions, or then we talk about efficacy and potency, right? So drugs, two drugs, we compare that which is more efficacious than the other or which is more potent than the other. So then we use the terms that efficacy and potency. Both of them more or less mean the same, but here the term used is efficacy and potency. Same graphs, if I make one graph here. So this is the graph, this is log dose, we plot here, and the response we plot here, okay? So we have three drugs. This is drug A, this is drug B, and I have another drug, drug C. So here I have to comment about potency and efficacy of three drugs and compare them, right? So let's see how we can compare this for us. Now, efficacy is what? Efficacy is the maximum effect that is produced by a drug, right? And this is determined by the height of the curve. Height of the curve. How tall the curve is in this graph. Okay. Potency is the amount of drug required to produce a certain response or a given effect or a response. And this is determined by the position or the log dose, on the log dose, right? So it is left to right, determined by left to right shift. So if a drug is more towards the left side, it is said to be more potent than if it is on the right side for the same response. So here we have three drugs, A, B and C. Now if we want to compare the efficacy at a given response, so let's say our given response, this one, okay, this is a given response, and here I want to compare the efficacy of three drugs, right? Potency rather here, potency of the three drugs at a given response. So potency here, how can I say, for this particular response which A, B and C have achieved, what is the dose which is required to produce a response? So if I comment on potency here, so I can say, see, the more left the drug is, more potent the drug is. So we can say A is more potent than C and it is more potent than, because A is more towards the left, then is C and then is B. As you go on towards the right, because the dose required to produce that response is going on increasing, so you can say that the potency will be decreased. So as you move towards left to right, the potency is going to decrease. So potency, if you have to compare, this is the comparison. A is more potent than C than B. Now let's compare the efficacy. What is efficacy? The maximum effect is produced by a drug. So we just have to see the height here. So here we compare the height. What you can say, that A and B, they have similar height. So we can say A is equally efficacious to B, but they are more efficacious than drugs. So this is a comparison here, right? So a simple mnemonic to remember, we can say a mnemonic of HELP, H-E-L-P. H is height. Height stands for efficacy. So more the height, more the efficacy. L is left. More towards the left, more drug would be potent. So remember this, help mnemonic. All right. So moving on to the another important topic, that is the receptor type. So sometimes we have exams make questions that you identify what is the type of transducer system or what is the type of receptors that they are. So we have the G protein coupled receptors, which are of three types mainly, S, I and GQ. So their transducer systems vary. So GS, there is increase in the adenylyl cycle, increase, they stimulate the adenylyl cyclase, increase the cyclic GMP. GI is opposite to GS. GS is G stimulatory, GI is G inhibitory. So it will just do the opposite to what GS is doing. So it is going to decrease the or inhibit the adenylyl cyclase, and it is going to decrease the cyclic AMP. Also, it leads to potassium channel opening. GQ has a different transducer system. It activates phospholipase C and basically cause increase in the calcium concentration. Now, let's do the examples. Now, remember a trick here again. In GS system, most of the receptor on which there is the, which have a GS attached to them, so you will see that they bring about smooth muscle relaxations, not contractions, smooth muscle relaxation, right? Exception is there, but most of it will bring about smooth muscle relaxation. So if you're asked to identify the receptor which is a GS, you just see what is the action on those receptors. So for example, we have a receptor B2, beta 2. Beta 2, what does it cause? It causes bronchodilation. Beta 3, what does it cause? It causes uterus muscle relaxation, bladder. So urinary bladder. So urinary bladder relaxation, right? Detrusor relaxation, not the uterus, urinary bladder relaxation. Then we have adenosine. 2, it causes vasodilatation, right? And glands, if they are present, they lead to increase in the secretions of the gland. That's also another important thing. So for H2 receptors, they increase the secretions of HCl. The only exception here to the rule is your beta 1 receptor. So beta 1, it is also GS, but here there is contraction. It causes increase the force of contraction. That is the only exception to the rule here, right? So it can be, you can be tricked into like they give you beta 1, but it causes contraction. But remember, this is it is a GS type of receptor, but exception is that it causes increase in the force of contraction. GI would be different in the sense that most of the GI, you will see that they cause decrease in the either neurotransmitter release, or they also cause decrease in the secretions, right? So let's see examples. For example, alpha 2, right? So alpha 2 is what it's going to cause. It is going to cause decrease in the noradrenaline secretion, right? Then we have M2, muscarinic. Again, it causes decrease in the heart rate, depressant effect. D2, it causes decrease in the prolactin levels, right? Then we have mu, kappa. They work as analgesics. How? Because they cause decrease in the substance P. Then there is somatostatin. They inhibit the growth hormone. So they are the inhibitory nature, or they decrease the neurotransmitter release. They are wherever they are going to inhibit something. Okay. GQ. Now GQ interesting. They cause increase in the calcium concentration. So definitely wherever they are going to bring about increase in the contraction. So they are going to cause contraction of the smooth muscles, right? So we have alpha 1, which causes vasoconstriction. M1, M3, they can cause bronchoconstriction or urinary bladder contraction. H1 causes bronchoconstriction. V1, it causes vasoconstriction. Oxytocin causes uterine contractions. So it's a very easy way or understandable way to mug up these receptors, because even if you don't remember, it's very difficult to then remember which of the one is GS, GI. But just if you know the way these receptors act, what is the mechanism, what do they ultimately do, you can easily identify that this is the kind of receptor these are. So this is a very good way of, when you understand this, you can easily identify what type of G protein coupled receptors there are. The others are easier to, comparatively easier to remember, because they have very distinct mechanism. You can easily, and there are very few examples. But for GS, GI, G protein, so there are so many receptors which are from G protein. It's very difficult sometimes to mug up all of them. So this is a easy, fun way to actually understand and mark the answer. All right, moving on to the ion channels. Now, these ligand-gated ion channels, they have, when an agonist binds to these channels, they cause the movement of the ion. So, either they can be positively charged ions, or they can be a negatively charged ion, or the ion can be moving from outside to inside or from inside to outside. Right? So, depending if it's a positively charged ion, so they are going to stimulate the cell. If it's a negatively charged ion going inside the cell, it is going to inhibit. So, either it can be an inhibitory neurotransmitter or a excitatory neurotransmitter, or any of these things. So, very, very good, or three classic examples which are asked is the nicotinic receptors. So these nicotinic receptors, they have sodium ion channels in between. So when acetylcholine binds to this, for example, in the neuromuscular junction, we have the NM receptors. So when acetylcholine binds to this, what it does? It causes increase in the sodium ion, so the muscles will contract. So skeletal muscle contractions because of this. Then we have GABA receptors. GABA A in the brain, when GABA binds, or when, let's say, benzodiazepines bind, or GABA binds, which is the endogenous ligand here, what they do, they bring about the movement of the chloride ion. So that is inhibitory nature. That's why they are inhibitory neurotransmitters, or benzodiazepines. Therefore, it is used in cases of epileptic attacks because they inhibit the excessive firing of the neurons. Then we have the glutamate receptors. So glutamate receptors, when glutamate binds, it's an excitatory neurotransmitter, and there is movement of sodium and calcium, which is going to excite the neurons. So that's why it's an excitatory one. Then we have the enzyme linked receptors in tyrosine kinase, JAK-STAT, cyclic GMP, all these kinds of enzymes. So in the tyrosine kinase is linked, while in JAK-STAT it is not linked, it is separate. So what are the important examples here that we should know about? One is insulin, one is prolactin, whereas all the cytokines are important, growth hormone, right? So these are the examples of the enzyme linked receptors. Then we have the intracellular. So intracellular means inside the cell. So they can be present in the cytoplasm, or they can be present in the nucleus. Ultimately, the ones done in cytoplasm also, they have to enter the nucleus, because they are involved in the protein synthesis. So remember, the fastest ones are the ion channels in milliseconds, and the slowest are the nuclear receptors, because they require the formation of protein synthesis. So first we'll do the cytoplasmic ones. Remember the mnemonic SAD. SAD, SAD. So here we have steroids. Then we have androgens. And then we have vitamin D. The rest of the hormones, basically, they are in the nuclear ones. And it's, another one is vitamin A. So vitamin A, estrogen, progesterone, thyroxine. So they all are the nuclear type of receptors. Okay, so let's move on to the next important topic is the graded versus the quantile dose response curve. So dose response curve. So we have the first one in the graded dose response curve. What is the meaning of this is that this is the log dose and this is the response. So as you go on increasing the dose of the drug, the response is also going to go on increasing. So you go on increasing the dose of the drug, the response will also increase. That is the log dose response curve. So log dose response curve, ideally the shape is, what is the shape? We say it is a sigmoid shape. If it is a dose response curve only, then it's a hyperbola, the shape. But this is an S-shaped or a sigmoid curve. So this is in the response. This is in a single individual, right? The dose you give in a single individual, the response it produces. So it is in a single individual only, right? And what can you actually assess from this particular graph, such graph? You can comment on the efficacy of drug, right? You can comment on the potency that we did before, right? So two drugs can be compared. You can comment on selectivity, how selective the drug is. For example, is a drug like a salbutamol. So we say that salbutamol at the dose of 100 micrograms produces bronchodilation, while at the dose of 600 micrograms, it will also cause increase in the heart rate. Why? Because at 100 micrograms, it is more selective for the beta 2 receptors, but when you increase the dose, selectivity is lost. It also starts stimulating beta 1 receptors in the heart. But you have to go 6 times the dose, right? So we can say it is selective in action. Let's say there's another drug which acts on the beta 2 receptors at 100 micrograms, but if you increase the dose to 200 micrograms, then it stimulates beta 1 also. So then we say it is not very selective, right? So there should be a gap between the effect which is desired therapeutic and the adverse effect. So you can tell about the selectivity of a drug. Then we can comment on the slope of a drug. So if a drug is like, slope is this, very steep, that means with smaller doses, there's an enhanced response. But if the dose is flat, that means it is a safer drug. Even if you're going increasing the dose of the drug, you won't have a dramatic change in the response. So all this can be made out from the graded dose response curve. But the quantile dose response curve, this is studied in a population. So that was in an individual, this is in a population. And it's usually there is a response, it's a binary response, yes or no response. So either the drug is producing this or the drug is not producing the effect. For example, sedation. So you will have a drug which produces sedation in 50% population, or it does not produce sedation 50% population. So that is a quantile dose response curve. Now here we have the important concepts here of two, which is therapeutic index and therapeutic window. So what is the important concept? Now this is therapeutic index here that we have shown. So this one here is the therapeutic window. Okay. Now in therapeutic index, it is actually indicating, or it's an indicator of safety. Very important. It is an indicator of safety that is asked in the exam. So what is therapeutic index? So therapeutic index is calculated by LD50 by ED50. Dose which produces the lethal effect in 50% of population over the dose which produces the effective or response in 50% of the population. But I want to tell you, this is not the population of humans that we're talking about. When we talk about death, LD is death. That we cannot do in a human population, right? So LD50 is a term which is used in animal studies only. While in humans, we replace this term LD50 as TD50, toxicity in 50% of the population. So this is a term we use in humans. Okay, now this is a mnemonic I put, TILE, tile. TI stands for therapeutic index, L stands for LD50, E stands for ED50. So how to calculate, if sometimes they ask you, can you calculate here? So if in this graph, if you are asked to calculate, what you have to do? You have to divide TD50 over ED50. So this is the 50% response. So you say the dose which is required to produce 50% response, toxic effect, is 35. So this would be 35 divided by here 15, right? So this is the answer here, right? So roughly about 2.3, or we can say roughly about 2, right? So what does it mean? That you have to, TD50 is equals to, let's say, around 2 times the ED50. So twice the effective dose. If you increase the dose by 2 times, the toxicity will appear. But let's say on another hand, we have a drug where the toxic dose appears at a much later rate. So let's say it is 125. The TD50 is 125 divided by this. So what will be happening here? So it is 5 times. 5 times you require the effective dose, and then it will be a toxic effect. So can we say the drug here? So the drug which requires 5 times its effective dose to produce the toxic effect is much safer than the drug which requires only twice its effective dose to be toxic to the population. So it is an indicator of safety. More is the therapeutic index, then higher would be the safety margin. So the more safe therapeutic index means more safe is the drug. Less would mean less safe is the drug. That is, therefore, it is called as the indicator for safety. But what is therapeutic window? Therapeutic window just means it is the window between the minimum effective dose and the minimum toxic dose, right? So this is called as therapeutic window, and clinically this is more important, right? So for clinical practice, this is more important, and we actually see this only. So what is if you go below the dose, the effectiveness will not be there. If you go above the dose, then there will be a lot of side effects which come into picture. So this is more important clinically, but you should know the difference between therapeutic index and therapeutic window. So these are the few drugs which have a very narrow therapeutic range or therapeutic window. So the importance is that if you have to be very careful while dosing these drugs, otherwise there can be toxicity or you can land into decreased effectiveness. So digoxin 0.5 to 1.4 nanograms per ml, and lithium for maintenance you require 0.5 to 0.8, but acute episode you require slightly higher dose, and you should maintain it at the plasma levels of 0.8 to 1.2. Phenytoin is 10 to 20 milligrams per deciliter, theophylline 5 to 15 micrograms per ml, valproate 50 to 100 micrograms per ml. So such drugs which have a very narrow therapeutic window, they are actually a candidate for therapeutic drug monitoring. So we keep on monitoring the drug levels so that we know that we are dosing, whatever dose we are giving to the patient, it is falling within the therapeutic window or not. So with this comes another important question: which drugs, or give examples of drugs which require therapeutic drug monitoring? So we have a mnemonic for this: gentle digits having very low therapeutic index. So gentle digits having very low therapeutic index. So let's see them. What are these drugs? So we have gentamicin, digitalis. So this is hydantoin. Hydantoin is a chemical name for phenytoin. Then we have vancomycin or valproate as well. Lithium. This we have theophylline, right? And tricyclic antidepressants also. TCAs actually, they have a variability of response in the individuals, right? So no two individuals who might require the same dose of the drug. So that's why another we have to monitor this. I stands for immunosuppressant. Immunosuppressants. So these are the important examples of drugs which require therapeutic drug monitoring. Coming to the types of antagonism, what are the different types of antagonism which we see? One is physical antagonism. Now, this is based upon the physical property of a drug. Based on physical property of a drug. For example, activated charcoal can absorb alkaloids. Okay. Chemical antagonism means two drugs they react chemically. React chemically. Or a chemical agent, a drug with a chemical property will produce the effect which is of chemical nature, right? So for example, we have a chelating agent which will react with the poisons or the heavy metals. Iron will react with desferrioxamine, right? So this is a chemical reaction that takes place. Then physiological antagonism. It's a very interesting antagonism that the two drugs, they act on different receptors, but they produce response in the opposite direction, right? So two drugs, they act on different receptors, but they produce opposite response. This is a very commonly asked antagonism, and a classic example here is adrenaline. Adrenaline and histamine. See, why adrenaline is a drug of choice for anaphylactic shock. Anaphylactic shock, the main mediator is histamine, but we use adrenaline because the major issue, like histamine, it acts on the bronchial muscles and it causes bronchoconstriction due to action on the H1 receptors. Now, adrenaline acts on the different set of receptors, but it causes bronchodilation. So, therefore, it's life-saving in case of anaphylactic shock. Similarly, we have glucagon and insulin. So they have different set of receptors, but one produces increase in the blood glucose level, the other produces decrease in the blood glucose levels. Then receptor site antagonism. Now receptor site is simply that one drug blocks the receptor for its agonist. So agonist is another drug and it acts on its receptor. So this is a, let's say, the receptor. Normally an agonist would come and bind, but what is the antagonist going to do? Antagonist is itself going to bind here, right? So this is the antagonist, AN. So this is called as a receptor site antagonism. What is the example here? Let's say the agonist is acetylcholine, right, on a muscarinic receptor, and the antagonist is, right? All right. So this antagonism, again, this receptor site we have already done before again. So this is the graph of two types of antagonism that can be seen. One is competitive and the other one is non-competitive. So this is the graph which is only with the agonist. So this is when you add a smaller dose of an antagonist and then you add a larger dose of antagonist. It's a competitive antagonist. Remember, for competitive antagonist, the graph will always shift to the right. So again, you see here, the efficacy is the same here. If you're talking about the receptors, right? So efficacy is same height. Help, again, HELP. Height is same, efficacy is same. Now let's see low, L is left and potency, which is more towards the left with agonist. So as you go on giving the competitive antagonist, because more dose is now required of the agonist to produce the same response in presence of a competitive antagonist. So you will see here that the potency goes on decreasing. So there is decrease in the potency. But if you talk about non-competitive, what is happening here? This potency, it remains the same. But because the height is going on decreasing, so that means the efficacy is dropping. The maximal effect is dropping. So decrease in the efficacy is there. Okay. Let's move on to another concept here, which is a hospital is conducting a multi-center study to evaluate the efficiency of statins. Each center includes 4 to 5 patients where half receive the drug and the other half receives a placebo. The drug is double blinded. The study is double blinded, meaning that neither the patient nor the clinicians know which drug is being administered. Which phase of the clinical trial best describes this scenario? Whether it is phase 1, phase 2, phase 3 and phase 4. Okay, before we answer, let's study these phases first and then we come back and answer the question. So clinical trials, so initially we have the preclinical studies. Preclinical studies which is done in animal, right? Which is done in animals, or they call toxicity studies and all, and an investigational new drug application is filed. Then if it is approved, it enters into the humans. Now, the mandatory phases start from phase 1, but there is a phase 0, which is not a mandatory phase, but some companies can choose to do this. It's on a very small group of people, healthy human volunteers, and there's no blinding required because they're not patients. No blinding is required. What is the aim basically? We use very, very small dose, less than 1/100th of dose. The aim is to obtain information about the pharmacokinetics. To obtain pharmacokinetic information, right? Because let's say if it is not a suitable pharmacokinetics, we don't want to go into the expensive trials, right? So if we find that it's not very suitable for human use, or the kinetics don't match, then, or it's very not bioavailable or something like that, then we won't want to go into the expensive trials. That's the main aim of this, but it's not a mandatory phase. Mandatory phase starts from phase 1. Now, phase 1, it's mostly dealing with the safety, pharmacological and safety. Again, these are healthy people, 20 to 80, no blinding is required. So, this actually just tests the safety. Most important thing is safety and what is the maximal tolerated dose. That we have to see from the, what are the dose ranges that you can, that ideal range you can identify from this. The second phase is the therapeutic exploratory and dose ranging studies also. Now here the patient, they will grow more patients for 2 to 4 centers. Now here actually the patient starts in phase 2. It can be blinded, can be open label. Blinded means either can be single, double blinded, or open label means when both the patient and the healthcare provider also knows what is being given to the patient. Now this is actually to know about the efficacy and the dose range. Now the third is to compare. So here now you have explored that it is therapeutic. You know now it is therapeutic. Now you want to confirm. You confirm it against an already present active drug for that particular disease. Active comparator is there. So you are going to confirm whether it is as good as the previous drug, or it is less effective or more effective, less adverse effects. So what is it? It stands apart. Either it should be equally efficacious and maybe cheaper, or it should be better than the previous drug. So it involves a larger number of centers and more patients, and it is usually double blinded, randomized control or uncontrolled, but it is usually this is the way the trials are designed here. Now this actually is the best phase to confirm the efficacy. So it is the best phase to confirm the efficacy. And we can also tell about the safety of the drug. So when we have all the good reports or good data after phase 3, then the new drug application comes. It is submitted to CDSCO in India, and or rather to the FDA in US, if it is a US trial, if it's taking place, FDA US. So then they study this, and ultimately now the drug enters into the market. So that is where we do all the other studies like post-marketing surveillance, pharmacovigilance studies, etc. are done. And now the every person will start, all the healthcare providers are going to prescribe the drugs now to a whole lot of population. It's a huge population, obviously. So what is the aim here? aim here is that you can even find out about the rarest of the ADRs. So the rare ADRs can be detected, rare ADRs. And you can also see the effects in the other population groups which is not done before, like in elderlies or in the pregnant females. So they can also be studied. So rare ADRs basically are done or they are found here because of long-term ADRs, because you're giving the drug for long period of time. The long-term ADRs, they also can be found out. And this is the phase where you do the ADR monitoring. So it's post-marketing surveillance or also called as pharmacovigilance studies. They're all done in this phase, right? So in this pharmacovigilance studies, what they do is that all the healthcare professionals, they are responsible. So they can collect the data. They have a form they can submit and they can collect data, and they will further submit it to the ADR monitoring centers. Like it can be medical colleges, hospitals and all, there are centers there. So they can give this information there. And then we have various zonal offices for CDSCO, which is in Ghaziabad, in the north, east Calcutta, south Chennai, west Mumbai. So they can submit there. And then at the national coordinate, the whole information is sent at the National Coordinating Center, IPC Ghaziabad. So you have a form which is called a VigiFlow. That's the software through which the forms can be filled. And then it is sent to the CDSCO headquarters in New Delhi. Then to the main center, Uppsala Center, which is in Sweden. And that is how it is communicated. And they then further send it to the FDA and they review it. And if there's a black box warnings and all, they can come into picture. If they find that there's a lot of data regarding a particular kind of ADR on a particular drug, then either they can be withdrawn. They have the power to withdraw the drug, to issue black box warnings, whatever is there, that can be done. So this is how it is practiced. It's a very, very important thing to do. All right. Now we go to the answering of this question here. The question was that which of the clinical trial best describes? So you see you have each center. So it's a multi-centric study, right? So multi-centric study is there where there is a double-blind study, right? And where do you think it is possible? So if it's a multi-centric study, you see here double-blinding study. So this study should be phase 3 because this is a multi-centric study. So the answer here should be phase 3. If they ask you which is the best phase to study or confirm the efficacy, then also it is phase 3. So now next move on to this question is match the following teratogenic drugs with their associated teratogenic effects. So lithium, chloramphenicol, warfarin, thalidomide compared with phocomelia, depressed nasal bridge, gray baby syndrome, Epstein anomaly. So here you see lithium can cause Epstein anomaly, cardiac defect. Chloramphenicol causes gray baby syndrome. Warfarin causes depressed nasal bridge. Thalidomide causes phocomelia. So what is the correct answer here? 1D. So let's see 1D. We have C and D as the options. 2 should be C. So this would be the answer. 2C, 3B, 4A. So let's do some of the important teratogenic effects of various drugs which are contraindicated in pregnancy therefore. So ACE inhibitors or ARBs absolute contraindications because in the fetus they can cause renal defects. Right? So they can cause renal defects, they can cause pulmonary hypoplasias. Pulmonary hypoplasias. Warfarin can cause depressed nasal bridge. Depressed nasal bridge and brachydactyly. Small these digits. So this is a typical depressed nasal bridge seen with warfarin. Phenytoin causes cleft lip or palate. It can cause microcephaly and it can cause hypoplasia. Hypoplasia of phalanges which are not well developed. Right? So typically you can see here cleft lip that is seen with phenytoin. It's called as fetal hydantoin syndrome and this is called as fetal warfarin syndrome. Valproate. Now, valproate, one of the most toxic teratogenic drugs. It can cause neural tube defect and spina bifida. Lithium can cause, it is rare, but it can cause cardiac anomaly, like it can cause Epstein's anomaly. Carbimazole, methimazole, this can cause choanal atresia, can cause esophageal atresia, it can cause fetal hypothyroidism or goiter, and it can cause aplasia. Thalidomide, we all know it causes the phocomelia or seal-like limbs, right? So here, this is the thalidomide phocomelia, and this is the aplasia cutis, which means there is absence of skin on that area, right? Aplasia cutis. Then tetracyclines, they can cause bone defects and yellow deformity. Aminoglycosides can cause fetal ototoxicity. Fluoroquinolones can cause cartilage defects and tendon damage. So these are the most important teratogenic effects, and what are the teratogenic effects that the organ damage that they cause. Now, in the pregnancy drug categories, we should not confuse it with the schedules. Don't confuse this. These categories, they are from A to X. A, B, C, D and X. So, D and X, these are the teratogenic drugs. Both D and X are teratogenic drugs. But D, we will see if the benefit is more, then we might use them. For example, we have valproate in them. But X, they are absolutely contraindicated. The risk is more than the benefit. So, they are absolutely contraindicated. So, like thalidomide, warfarin. Now, A, B, C, they are safer drugs, and this is the safest out of the lot. So, this is what you should know about this. So, what are the safe drugs which can be used in pregnancy in various conditions? So, for example, there is hypertension, which antihypertensives we can use. So, we have labetalol, we have methyl dopa, we have nifedipine, sustained release, and then we have hydralazine. So, for hyperthyroidism, first trimester, we use propyl thiouracil, and then second and third trimester, we can use carbimazole or methimazole, because propyl thiouracil is hepatotoxic, can't use them for long term. Methimazole. Epilepsy, we have lamotrigine and levetiracetam. Bipolar disorder, atypical antipsychotics. Anticoagulant, we can use low molecular weight heparin, or heparin can be used. Antimicrobials, beta-lactams like penicillins, they are safer, and erythromycin. Or antimalarials, the best drug is chloroquine, that is safer. So these are the drugs which can be used in pregnancy. Then drug schedules, important. What is the meaning of each schedule? Schedule H. H means hum. Hum in Hindi means us. That means we can prescribe. So these are the drugs which require prescription. So they are sold under prescriptions. G means guidance. So they need supervision. right? Or guidance for administration. Schedule X. X is danger. So these are your psychotropic drugs. Psychotropic drugs, which are kept under lock and key usually. Then schedule Y. Why do you need? Answer the question. So these are the clinical guidelines for clinical trials. Clinical trials. So now we have the new drugs and clinical trial rules 2019. So now we don't use the term schedule Y, we use new drugs and clinical trial rules 2019. Schedule P, P means period, so it tells about the expiry period of a drug. Expiry period of the drug, or the shelf life or expiry period of the drug. W means worldwide. So all over the world, you can only, these drugs, they can be marketed under the generic name only. So these are drugs marketed under generic name. Z. It was a recent question and this is regarding the veterinary medication. Okay. So these are the important trials and how you can remember by associating them, right? Then few examples of pharmacogenetics which are asked, because this certain population, we are different and we have different enzymes, the way the enzymes function, that some have a fast acting enzyme, some might have a slow acting enzyme. So they can actually change the way a drug behaves in different individuals, right? Some of the important examples you're going to do. First is, there's a drug for tuberculosis which is called as INICET. Now, INICET is metabolized by acetylation. So, some population, they are slow acetylators which metabolize them slowly, or others are fast acetylators. So, the difference will be, in them, that some will have hepatotoxicity more, some will have the neurotoxicity more. That will depend. So, INH acetylator status can be slow or can be fast. This is how the effect can vary in population. The other drugs which are metabolized by acetylation, so these are your shipped drugs, SHIPD, shipped drugs. So we have sulfonamides, hydralazine, INH, procainamide, and dapsone. So they all will have the same problem. Acetylator status is there. So the effects can be different for different population. Then in some population, we give succinylcholine when we give, it's a neuromuscular blocking agent and it gets metabolized by an enzyme, pseudocholinesterase. But in some population, they have a pseudocholinesterase. Pseudocholinesterase. So what happens in them is that they metabolize the drug very slow. So in such people, there can be succinylcholine apnea. Then people who are G6PD deficient, they can have hemolysis if you give certain drugs. Which are the drugs which can cause hemolysis in this? For example, dapsone, anti-malarials, especially primaquine. Primaquine, more than chloroquine and more than quinine or quinidine or quinine. Then INH, then sulfonamides, right? So then we have methylene blue, methylene blue or methylene blue. Okay, so these are the important examples. Then enzyme TPMT. In people where there is deficiency of this TPMT enzyme, what will happen? Drugs like azathioprine, which is metabolized by this. or 6-mercaptopurine, because they require TPMT for metabolism. So they will not be metabolized. So this will lead to increase in the bone marrow toxicity with these drugs. We have CYP, enzyme deformity or deficiency or abnormality, right? Abnormality. Certain drugs are activated by these CYP enzymes, they will not be activated, right? So we have CYP2D6. So codeine, it gets activated to morphine with this. Now if this is deficiency, then codeine will not get converted. It's a prodrug. It has to get converted into morphine. So it will no longer be converted into morphine. So it will not have any analgesic action, right? So for warfarin, CYP2C9, for warfarin, it will not be activated properly. So again, it will not behave in the similar manner in the patients. It have a different variable response in different cases. All right. So these are the important examples for pharmacogenetics. Let's move on to another PYQ and then we'll understand what are the different these names or what are the different information that we need to know about this. A pharmaceutical company labels a drug as containing 500 milligrams. So the company labels a drug which contains 500 milligrams of paracetamol, but when you analyze this, we see that drug only contains 200 milligrams of paracetamol. What is this type of drug classified as? So the strip says 500 milligrams paracetamol, but actually there is only 200 milligrams of paracetamol. So what kind of drug is it? What kind of a counterfeit drug is it? So let's see the different definitions here and then we come back to the answer. So first we go on what is a spurious drug. Spurious drug is a drug where you have a wrong product or which is substituted partly or completely by another drug, or it can be an imitation of another drug manufactured under a name which belongs to another drug. So let's say one company like Cipla is very famous and there's a local manufacturing unit or company which is making, it is selling the drugs by copying the Cipla, the whole thing. It's writing Cipla only on its strip, which is illegal because it doesn't contain the same product as Cipla. So this is called as a spurious drug, right? Misbranded drugs are the drugs which are not labeled in the prescribed manner and they're made to appear better or they have false claims. So just like this drug, it is not labeled properly or there is a false claim, claims that it has a 500 milligrams of a drug, but actually it contains only 200. So it's a false claim. Adulterated drug, which means it is prepared, packed or stored in insanitary conditions, contains harmful substances or filthy substances. For example, there is a manufacturing unit which was making calcium tablets, and without cleaning up properly the machine, they also started making paracetamol tablets. So in the paracetamol, there is some amount of calcium also present. So this is called as an adulterated drug. So it can happen. Then orphan drugs are drugs that are made for the rare diseases, right? Very rare diseases in India, which affects 1 in 5,000 population. So for example, bortezomib for multiple myeloma, eculizumab for PNH, desferrioxamine for iron poisoning, etc. So these are the orphan drugs, right? That is the important thing here. So out of all these, if you go back to this question, so can you tell me that which is the correct answer here? As I said, it is making a false claim, that is 500 milligrams paracetamol, but actually it's containing 200. So this is called as a misbranded drug. Okay. Then, so this is actually a tablet or a strip showing you what all information should be contained. So it's a name of the drug should be there, the composition should be there, the various temperature it should be there, the name of the company, caution, everything all should be mentioned as such, right? The expiry and all. So this is a complete information that an ideally a drug strip or a drug, that brand, it should contain. So essential EDL is essential drug list. What is essential drug list? Is a list which can differ from country to country because it satisfies the healthcare need. The healthcare need for the majority of population. For the majority of population, right? So it will contain the medications which are most important for that particular area or this region or the country, because more people are suffering from that. So it is more, actually you can say it's more relevant to that particular country. So usually the essential drug list, they have drugs which are cheaper, right? They are in single, they're not combination, they are single drugs. Mostly they're cheaper, they are single drugs, and many favor even the generic drugs. So they should be cheaper, they should be easily available, they should be mostly single drugs, generic form, and that is how the essential drug list is made. So these are the various important concepts, or you can say the various definitions when we talk about different drugs. So these are the drug storage temperatures. What it means that you store the drug at room temperature. What it means that the temperature should be between 15 to 25 degrees centigrade. If they say that cool and dry, it should be between 8 and 15 degrees. Refrigerate means between 2 to 8 degree, and defreezing means it should be minus 15 degrees centigrade. So sometimes the MCQ asks you what is the meaning of the temperature range for room temperature, cool, dry, refrigerate, or defreeze. So with this, we come to the end of this topic of pharmacodynamics.